Okay, hello everyone, and welcome to another session of the Virtual Global Spine Conference. My name is Ali Baaj. It is a pleasure to be here with everyone today. And today I will be hosting and taking on this session. It's a little bit of a special session. We do this every 6 months or so, where one of us, either us or an invited guest, spends time on reviewing some cases, primarily spine cases that are potentially relevant to colleagues who are preparing for the oral boards examination, or certainly trainees, residents, fellows, etc. Every 6 months, we do this special session where it's a little bit off topic and more dedicated to specific cases. So that's what I'll do today in the next, let's say, 30 minutes or so. We'll go over a few cases, and if anybody has any questions, feel free to use the chat box. Otherwise, we'll go ahead and go right in. And obviously, it goes without saying that although many of us who do this virtual spine sessions, many of us are either neurosurgeons, orthopedic surgeons, neuroradiologists, et cetera. We work at mostly academic institutions, and we do a lot of teaching. So we have a repository of cases that we review. But just so nobody gets upset, I have to put this disclaimer that none of these cases are actually necessarily, on the actual board's exam for any entity, orthopedics or neurosurgery. And I personally have no knowledge whether similar cases are there or not. So just a disclaimer there. I'm not sharing any inside information that I may be aware of. These are actually just a repository of cases that we've had over the years. But hopefully they'll be helpful to colleagues who are potentially studying for upcoming examinations. So here is the first case, and what we're going to do is go over some history, some exam findings, some neuroimaging, and then I'll talk about what some of the things that folks look for and really what the salient points are. And this is one such. This is a sample case here. This is, let's say, a woman in her 50s who has been having difficulty walking with numbness from the chest down without any bowel bladder dysfunction, otherwise healthy. And examination shows that she has full strength in the upper extremities, lower extremities, a little bit hyperreflexing in the lowers. And from a sensory perspective, she has diminished sensation to pinprick below the nipple line, below the chest area. And right off the back, before even looking at the neuroimaging, what comes to mind is, okay, well, based on this history and exam, can we localize the lesions? Anytime you deal with these kind of exams and these questions, you kind of want to localize the lesion, have a differential diagnosis, and then ask for additional imaging or additional information that can clinch a potential diagnosis. So from the history, we know she's otherwise healthy, difficulty walking, diminished sensation from the waist down. So now we're thinking maybe something, obviously neurological, probably in the thoracic spine, right? Since upper extremities are good in terms of reflexes, but the lower extremities now there's hyperreflexia, there's difficulty walking, it's just probably a thoracic lesion. And really on the exam where we have a diminished pinprick to but below a specific area, in this case, the chest or the nipple line, that's usually T4, T5. And of course, if it's the umbilicus, that's usually T10, T11. So now we say, okay, well, let's see an MRI, right? Let's see some advanced imaging. Let's see an MRI. Let's see if there's anything in the thoracic spine that could be the issue. You ask for a thoracic spinal MRI, and this is what you get. So you'd be asked to comment on what you see, what type of scan this is, right? Is it an X-ray, a CT, or an MRI? Obviously, everybody knows that this is an MRI. Usually, somebody will say this is an MRI with contrast, or this is a T2 weighted image, etc. But basically, on this scan here, the major finding is that there's a lesion, right? There's a lesion in the spinal canal. And in the neurosurgery world, anytime there's a lesion in the spinal canal, you want to be able to say what part of the canal it's in, and especially relative to the dura. So if we start from the, say, the outside in, is it completely extradural, right? Is it extradural? Is it like epidural disease, abscess, hematoma, infection, etc.? Is it intradural? Is it within the dura but outside of the spinal cord, what we call intradural extramedullary? Or is it intramedullary? Is it within the spinal cord itself? So one of the key points for trainees and fellows and folks who are taking exams like these, either on the orthopedic or especially on the neurosurgery side, is to be able to understand where the lesion is, if it's intramedullary, extramedullary, intradural, or extradural completely. And then you would have to discuss why you think it's one of the above, if you will. So this is, for various reasons, this is really an intradural extramedullary lesion. It is ventral. It has a little dural tail. It's heavily enhancing. So, the differential diagnosis now all of a sudden is an intradural lesion or tumor, meningioma, metastatic disease, lymphoma, etc. But an intradural extramedullary tumor of some sort, most likely a meningioma, is very high on the differential. And then after you kind of come up with the differential diagnosis, you narrow it down to say one or two possibilities. You have the imaging, you've correctly identified the salient points on the imaging. Well, what's the plan? And again, in the neurosurgery world, what's the plan in terms of, okay, is it surgical or is it not surgical? And regardless of which one it is, do you need more workup? Do you need advanced imaging? So in this case, somebody may say, well, this could be a metastatic tumor. Let's do a chest, abdomen, pelvis CT. Let's see if there's any systemic disease. Let's see if there are any other lesions. Let's look at the entire spinal MRI, the neuroaxis MRI, to see if there are any other lesions. And then, an examiner may say, well, hey, this is the only lesion. Okay, this is the only lesion. This is what you've got. And now all of a sudden it makes, metastasis less likely, and probably more something primary there, like, a meningioma. And then the final step would be, okay, what is the treatment for this? And there's typically a fork in the road here, right? Non-operative or operative. And more likely than not, you're going to see cases that are operative, right? These are surgical exams, if you will. You have to talk about surgery and how you do it. And when we are talking about intradural lesions like this, that we know we need to do surgery because we need to decompress the spinal element, the neural elements, the patient's myelopathic or is having neurological deficits, there's severe cord compression, they need surgery. Okay, great. What's the approach? Is the approach anterior? Is it posterior? Is it lateral? And if it's if it's anterior, lateral, or posterior, how do you do it? And we always talk, with colleagues that when we're reviewing cases like this, when you talk about an approach, you've got to make sure you understand how it works and how to do it, because they're going to ask you how you do it. And if you've really never done it or don't know how to do it, it's going to be evident. So you want to make sure you can articulate the different approaches that well enough, especially the correct approach or how you would do this. So in this case, without belaboring the point here, this is a ventral-based lesion. It is most likely a soft mass, probably meningioma. You can say, I'm going to get a CAT scan to make sure it's not calcified. But the bottom line is you need to decompress this. And for ventral lesions like this, where obviously now you're talking about T2, T3, you shouldn't be saying things like sternotomy or menubriectomy to do a corpectomy at T2. This is really more, especially in this area here, a posterior approach. But the key is not just saying it's a posterior approach. The key is saying, this is going to be a midline laminectomy. We're going to open the dura, but you have to be prepared with thoracic lesions, especially ventral thoracic lesions. You have to be able to articulate that you're going to go as posterolateral as needed. So you may need to do a transpedicular approach or a costotransversectomy so that you minimize any manipulation to the spinal cord. And that's the key when it comes to ventral thoracic lesions like this, whether it's a calcified disc or it's a ventral tumor. You can say, I'm going to attempt this posteriorly, but you don't want to say that I'm going to do this posteriorly, midline, laminectomy, open the dura, and, maneuver, displace the cord one way or the other. You want to say, I'm going to go lateral. If I'm not happy, I'm going to go more lateral. I'm going to take out the joint. I'm going to be ready for a fusion because I'm going to destabilize. So you want to make sure you can articulate the fact that you're going to employ posterolateral approaches safely for the thoracic spine. Now, if you have a very large midline calcified thoracic disc herniation, then we're talking about the anterior approach, and really none of the posterior or posterolateral approaches matter. And in some cases, they may be really incorrect. But for tumors in general, even if they are ventral tumors in the thoracic spine, intradurally, like this lesion is, you can definitely say we're going to do this from a posterior slash posterolateral approach. We're going to go lateral and potentially fuse. So this case really just highlights how you attack this. On many exams, you may have a complication where somebody says, okay, do the surgery, everything goes well, but then they come back to the ER, let's say a week or 2 weeks later, right? You always have to know how to deal with a complication, either intraoperatively or post-operatively. In this case, it's a post-operative complication. You have clear fluid coming from the back. This is most likely going to be a CSF leak. And it's a CSF leak because you went intradurally. You may or may not have been able to achieve a watertight closure the first time. So you have to manage this complication, right? And, there are many right answers. You admit the patient, you put a lumbar drain after you get an MRI, or you take him to surgery. The wrong answer is to say, well, just change the dressings and go home and call me in 2 days, right? Especially if it's clear fluid, because they can get meningitis. So you have to be able to deal with complications. And most of the complications, let's say post-operatively, are going to be CSF leak, wound infection, pseudoarthrosis, or certainly, hardware failure, adjacent segment disease, proximal junctional kyphosis or failure, distal junctional failure or kyphosis, delayed instability. Again, we're talking about spine cases here, of course, but these are the types of post-operative complications that you're going to have to deal with. And the reason those are the post-operative complications that you have to deal with on examinations like the board is because those are the real life complications, right? Those are the real complications we see in clinic and in practice after spine surgery: wound infection, spinal fluid leaks, pseudoarthrosis, hardware failure, et cetera, et cetera. So you got to get comfortable with those. And in a couple of cases, we'll talk about intraoperative complications. So you have to be able to address intraoperative complications, postoperative complications. This is another case. This is a woman in her 70s, I want to say, maybe 70-year-old woman who comes in with worsening neck pain, numbness and tingling in both hands, difficulty with fine motor control. So now, as opposed to the last case where it was from the chest down, now we're talking about arm and hand issues. No past medical history. You ask for an exam. You even get a picture here, and you can see on the picture you're trying to decipher, okay, what exam findings here, what physical exam features help with the diagnosis. You can see she has stigmata of rheumatoid arthritis. You can see she's got a Hoffman's bilaterally. She's got deformities, joint deformities in the hand and finger. So all of a sudden you're thinking, okay, this is some kind of arthritic process. And, in this case, rheumatoid arthritis. And then you have to know, right, as a spine surgeon, RA, rheumatoid arthritis, is a big deal, right? Because several things now have to kind of be in motion here. The most common spinal manifestations of RA. There are common manifestations of RA, rheumatoid arthritis. You need to be aware of those. Those include C1, C2 subluxation, subaxial subluxations, pannus formation at C1, C2, swan neck deformity of the neck. So a lot of things can happen in the cervical spine in patients with RA, and with this history, with this exam, you can, clearly say, okay, well, it sounds like the patient may be myelopathic. Let's look at some let's look at some spinal imaging. Lo and behold, this is what you get. You get that typical C1, C2 pannus that is not uncommon in patients with rheumatoid arthritis, and with spinal cord compression, myelopathy. And the question is, okay, well, what do you do next? All right, next I want some more imaging. I want some, maybe a CAT scan to see if it's calcified or not. I want to look at the integrity of the bones. I want to see x-rays to see if there's any instability, and I'll go to the x-rays for a second to look at C1, C2. Does it move? Is there instability or not? But the bottom line is, this is really the picture. And this is a picture of a C1, C2 mass with spinal cord compression. I like to show this particular MRI because this can be presented in so many different ways. This could be a tumor. This could be a pannus. This is not trauma, obviously, but there are many things that it can be an infection. There's a lot of things that affect the anterior craniovertebral junction, in this case, C1, C2. But with the history of RA, with that exam, it's really going to be a C1, C2 pannus. And now you have to talk about, okay, surgery or no surgery. Well, she's got myelopathy and severe cord compression. She needs surgery. Okay. And now the next question is, okay, well, what are you going to offer the patient? And this is where it gets a little dicey, because I think while most people, I think at this stage, are pretty comfortable with managing this, I've shown these slides to a few people before. We've talked with many residents and others before, and once in a while you'll get somebody say, well, let's do a transoral resection or transoral biopsy or a transoral decompression, which really, for all intents and purposes, is really no longer regarded as the first line of treatment for this. Perhaps in the old days, I even used to actually do quite a number of transoral surgeries for these, but now we really don't do that anymore. And the correct answer for a C1, C2 pannus is a C1, C2 fixation or C1, C2 fusion. What happens when you fuse? Well, number one, you're reducing that subluxation that you saw in the x-ray. And number two, as the fusion takes, this pannus will resorb. And often it takes about 6 months or so, actually. You're probably not going to see a big difference before, but by 6 months or so, you'll actually see resorption of that pannus and resolution of that pannus. A lot of times where, the follow-up question to that is, okay, you do a C1, C2 fusion for a pannus. Do you also do a C1 laminectomy or a C1, C2 laminectomy? Well, and the answer is yes. And the reason is, although the pannus will likely, in all likelihood, resorb with and regress with a fusion, you have ongoing spinal cord compression. The patient's symptomatic. Doing a decompression concurrently will most likely expedite their recovery. They will get better quicker. You're there. There's no reason not to decompress the spinal cord at the same time. So the standard procedure here is a C1, C2 laminectomy and fusion. The other thing where people get in trouble is they may say, well, we're going to do an O to C2 or an O to C3 fusion. And as many of you know, on a lot of examinations, especially in our world in neurosurgery, you really want to have a very, very good reason of why you're fusing somebody to the occiput. So you've got to have a great reason to fuse somebody to the occiput in these cases. You can get a CAT scan, and if there's tremendous destruction of the C1 lateral mass screws, maybe. If you feel that there is something structurally problematic with C1, you can potentially make that argument. But for a board's exam, you want to say C1, C2, unless you have a good reason to fuse to the occiput, as opposed, of course, to AOD, right? AOD, atlanto-occipital dislocation, which is a traumatic diagnosis where you clearly see distraction of the condyles over the C1 lateral mass. Well, that's different. That's an OC fusion. But this is a classic PANIS case that's related to rheumatoid arthritis, and the treatment is a decompression, but most importantly, a C1, C2 fusion. And if you say C1, C2 fusion, you have to say that you have to know how to do it, and you have to articulate how you do a C1, C2 fusion, including starting points and trajectories, really for any implant you place in the spine. And then the last thing I'll say about cases like this is some people say, well, would you go back and do a stage 2 transoral or endonasal decompression? And it's very, very valid to say, I'm going to wait 3 to 6 months. I'm going to reevaluate the patient clinically. If clinically they're doing great, we're done. If clinically they're not doing great and we rescan and we see that there's still cord compression despite everything that we did, you can say, I'll either do it, or if you don't do it, I'll refer to a colleague who knows how to do endonasal decompressions or transoral decompressions. But that should be a potential stage 2, not part of a stage 1. Okay, but you can always say, I'm going to reevaluate clinically and radiographically, and perhaps down the road in 3 to 6 months, do a second stage anterior decompression. And again, we talk about post-operative complications, CSF leaks, infections, hardware issues, adjacent segment disease and failure. This is a case in which a patient comes back in a couple of weeks with basically purulent drainage from the wound. And here the wrong answer, especially since there are implants in the body, is to say, well, we're going to give the patient some PO Keflex and come back to clinic in a couple of weeks. That's the wrong answer, right? There's a little bit of cellulitis. If the wound looks angry, but there's no drainage, there's no pus, the patient's not toxic, the labs are good, you can make an argument for close monitoring. But the white count is high, the SED rate and CRP are high, purulent drainage. This patient is coming in for a washout. And they're coming in for a washout. Everybody knows how to do that, but you may very well be asked, the following question is, okay, well, what do you do about the hardware? Does the hardware have to come out? Well, number one, hopefully you got a CAT scan or an X-ray to make sure the hardware in these 2 weeks haven't moved, and they usually, and it hasn't. But the correct answer is that there is no indication to remove hardware in an acute infection. Somebody has an acute infection, unless there's osteolysis, unless all of a sudden there is osteomyelitis, which is unlikely, right, in 2 weeks. The standard of care is not to remove hardware. In fact, it's to keep the hardware in and then do a washout, especially if it's titanium, because we know titanium is inert. Now, a question comes up often is, well, when do you take out hardware? When do you take out hardware after a spinal infection? Well, it depends. If there's osteomyelitis, if there is a recurrent infection, you're washing out the patient once and twice, and they keep coming back with an infection, well, you got to take out the hardware. You got to take out the hardware, treat the patient with antibiotics, and then re-instrument if needed. But for acute infections, you do not necessarily need to take out that hardware. Okay. And let's go over another case real quick. This is a patient who's 72 years old, comes to clinic with just a significant back pain, hip pain, leg pain. The pain shoots down the legs in both posterior and anterior. Exam is relatively benign, but she has a forward stoop posture with a little bit of hip asymmetry. And now you're thinking, okay, she's a little bit older, she has back pain, she has leg pain, her posture is a little funny, and now all of a sudden you're thinking of maybe some kind of lumbar degenerative process. So, you can ask a little bit about the symptoms. Hey, does the pain get better when she leans forward? What happens in the recumbent position? What aggravates the symptoms? What makes them better? What makes them improve? But in general, after you go down all of that and you say, okay, well, let's see what's going on in the back, you get an MRI like this. You get an MRI that shows multi-level central lateral recess foraminal stenosis, just degenerative disc disease, your bread and butter lumbar degenerative disease picture in a patient with back pain and leg pain and a forward stoop posture. And I show this case quite a bit, quite often actually, to folks who are taking exams like this, because the trap here, and there's a trap, The trap is to say, well, you know what, this patient has ABC, she has multi-level stenosis, I'm going to offer this lady a laminectomy. Or worse, I'm going to offer this lady a laminectomy infusion, L3 to 5, L2 to sacrum, whatever you want. Pick your poison. And that's really not that is not a good answer, because the correct answer here is, well, okay, we know what she has based on the MRI, and the MRI is good at showing you neural element compression, but we have no idea what her alignment is. We don't know what she looks like when she stands up. What are her sacropelvic parameters? What's her lumbar lordosis? What is her alignment is? And people who are going to say offer A, B, C, D surgery without asking for a full standing X-ray really get in trouble in these exams, and that's a big red flag. More and more in neurosurgery, because in the old days, if you will, we used to just do surgery on with an MRI and never check X-rays, and we know that's wrong, and we know that we should be getting X-rays, especially for these deformities. So you can't really offer that patient surgery without understanding the pelvic parameters, studying the SVA, the PI, the LL. I won't bore everybody here on this, but you've got to understand these parameters so you can make a thoughtful surgical decision. You may very well say, hey, you know what? She's old, she's frail, she has focal stenosis. I'm going to do a lami infusion from L3 to L5. That's okay. But you still have to say, I obtained the X-rays, I measured the parameters, I have awareness of the sagittal and coronal parameters. This is what I'm going to offer, but I've taken that into account. I'm not going to do a T2 to pelvis. Totally okay. But you have to have that knowledge. And then the other thing, which is even more important than getting the X-rays, is you want to make sure you don't rush a patient like this to surgery, right? Oh, a patient comes in with 1 month history of lumbar stenosis, neurogenic claudication, and she's on the OR table. Did you try pain management strategies? Did you try physical therapy? Did you optimize her? Does she have diabetes? Is she a smoker? Did you check for a bone density? So all of a sudden, this is now not just lumbar stenosis needs surgery. This is a lumbar stenosis, degenerative deformity. Is the patient optimized for surgery? And did she fail and exhaust non-operative therapy? So a lot of people ask, well, do I have to know how to do a T2 to pelvis with a L4 PSO? You don't have to know how to do that, but you have to know what the surgical plan is. You have to know, whether a patient needs a 2-column or 3-column osteotomy. You need to know how much correction a patient needs versus just decompression. So a lot goes on to cases like this, but it's very important that nobody says, well, patient has lumbar stenosis, we should proceed with lumbar laminectomy without taking these other parameters into consideration. And here we usually show a complication of, say, patient has surgery, she does great. You do, let's say, a T10 to pelvis, she does really well for 6 months, and then comes back with significant mechanical back pain right in the middle of the back at the very top part of the construct. And right away, obviously, you're thinking about PJK, PJF. So you get X-rays, and then you monitor these patients, or sometimes you have to take them back and revise them. But PJK, PJF is a common complication, unfortunately, of these long segment constructs. And you'll be asked about them. How do you treat them? How do you diagnose them? And how do you prevent them too, by the way, which is a whole different discussion. Let's go over one last case here that should really kind of round up here the different things we've been talking about. This is a little bit harder. This is a 50-year-old female with progressive right-sided mid-back pain that radiates around the flank to the anterior abdomen. Relatively normal exam, except that she has diminished sensation to pinprick around the umbilicus. Normal tandem gait, normal stride. The reflexes are benign. So all of a sudden, we're looking at a picture in which a patient doesn't appear to have myelopathy. She has full strength. She's got some strange or diminished different sensation around the umbilicus, and it's right-sided mid-back pain that radiates around. So nobody here is going to throw any zebras. I mean, this is spine stuff, right? So something's happening in the spine. We are going to do a couple of things. We're going to localize it. Okay, umbilicus, kind of right side mid back. Now we're thinking, okay, let's say T9 to T12, T10 to T11. Advanced imaging shows this is an MRI. It shows a lesion here at T910 on the right. It's a little dumbbell appearance. And now all of a sudden you're faced with the following questions. What's the differential diagnosis? What is the treatment? And first thing is understanding what the differential diagnosis here is. So it's a lesion in the right-sided foramen of T9, T10. It's dumbbell shaped. It's enhancing. So now we're talking about tumor, just like the first case, tumor, metastasis, maybe less likely infection. Okay, that's your differential. What do you want to do? Well, if she's asymptomatic and this was incidental, you can make an argument maybe for a biopsy, right? A CT guided biopsy, see what it is. And if it's benign, we'll leave it alone. She's symptomatic. She has a lot of pain there. She exhausted non-operative therapy. This is probably, this is affecting the nerve root there, the T9 and maybe T10 nerve roots as well. Slight or early compression on the spinal cord. So you probably want to get into this and take it out. And as with all spine tumors, you want to make sure that you don't skip the biopsy part. Now, if something like this, which is, you don't necessarily need to, excuse me, if something like this, you're like, you know what, I'm going to get into it. I'm going to debulk it. I know what this is. This is a dumbbell schwannoma, right? It's a classic appearance. You can make the argument for surgery, going in surgery and doing an open biopsy, but it never ever hurts to say, I'm going to do a CT guided biopsy first to make sure this is not a lymphoma, to make sure this is not a primary tumor, because that could change the surgical approach. If this is a lymphoma, it doesn't even need surgery. You can just do chemo or chemoradiation. If this is a primary bony tumor like a chondrosarcoma or, less likely, obviously, a chordoma, now you're saying, well, I can't do an intralesional resection. I have to do an en bloc. So it's always good when it comes to tumors, especially bony spinal column or sacral tumors, to get a CT guided biopsy. You don't want to go in there and find out that this is myeloma or this is lymphoma. So patient gets a CT biopsy. It's a confirmed schwannoma. Again, dumbbell schwannoma, and you go in and resect it. And of course, you have to talk about how you resect it, right? Do you fuse? Do you take out a facet? Do you go intradurally? Do you open the dura? Do you go lateral? So you have to be a little bit comfortable in addressing these tumors, these schwannomas, whether they are intradural or whether they're foraminal, extradural like this. But the point of this case is to make sure you know what the diagnosis is before you perform this tumor surgery. So always, always, always get a CT guided biopsy in these cases. And again, we talk about clear drainage. Patient comes back 2 weeks later with clear drainage from the spine. Probably well, not probably, right? Clear drainage. It's going to be CSF. Although the white count is normal, CRP is normal, so you're not worried about an infection, but you've got to deal with the CSF. So either admit, put a lumbar drain, keep an eye on them, or you take them back, you revise them, and then you keep an eye on them. But the point is you have to be a little bit aggressive with post-operative infections and post-operative CSF leaks. And I actually think we do have time for one more case. We're going to do just one more case real quick. This is a 45-year-old male, otherwise healthy, worsening back pain, especially when he was weightlifting. No numbness, tingling, just a lot of mechanical back pain when he was weightlifting, and it's in the lower back. Exhaustive conservative management, physical therapy, took pain medicine, still not getting better. Really neurologically, he's doing great, just a lot of back pain. So now you're worried about, okay, something's going on in the back, and then you'll say, okay, well, I'm going to start with an X-ray. It's always a good idea to start with an X-ray. It's never wrong to start with an X-ray and then escalate to an MRI in these cases. So we get an X-ray, and here it is. You'll be asked to comment on this. And what do you see? Well, you clearly see a spondylolisthesis here at L4-5. You see a pars fracture. So this weightlifter at some point probably suffered a pars defect, right? And he's got a spondylolisthesis. And if you say that, somebody may say, okay, well, what grade is it? So you have to know the grades of spondylolisthesis: grade 1, 2, 3, 4, and 5, depending on whether it's 25% slip, 25 to 50%, 50 to 75, or over 75. This looks like maybe it's like right there, 25%, maybe on the edge between 1 and 2 grade spondylolisthesis. You say, great, patient's got a spondy. It's a lytic spondy or an isthmic spondy because of that pars fracture. I want to see an MRI. And here's an MRI. By the way, that may actually be a different patient, but the point is the point is the same. You get a patient, you get this MRI, he has back pain, he's got a grade 1/2 spondy, and the examiner asks, okay, well, what do you want to do? Well, I want to take him to surgery. Not the right answer. The right answer is, did he exhaust medical management, right? He doesn't have a foot drop. He doesn't have neurological, symptoms. He's got back pain. Now we know he's going to need surgery, but you still have to go through the motion. Did he do physical therapy? Did he take pain medicine? Did he, maybe get an injection, epidural injection, or, obviously not so much indicated here because he doesn't have a radiculopathy, but you want to make sure you have exhausted non-operative therapy before you take a patient to surgery. And let's say it's surgical, and somebody's going to say, okay, you want to fix this? How are you going to fix it? And now you have to articulate how you would fix an L4-5 grade 1 to 2 isthmic spondylolisthesis. And by the time you're about to take the board exam, you hopefully would have done a lot of these in training and in practice, and you have to be comfortable in saying how you do it. Not how somebody presented at a recent conference, not on what's, robotic, anterior, posterior, minimally, like don't say anything that you don't do or you're not comfortable doing or you haven't seen, right? So most people would say, well, this is either a minimally invasive or open L4-5 laminectomy and fusion plus or minus inner body fusion. Great. Talk about how you do that. What are your entry points for the screws? What's your trajectory? Oh, I use navigation. Navigation is not working today. Okay, the nav system is broken. The O-arm is down, right? Give me your entry points. I use fluoroscopy. Okay, great. What's the length of the screw, etc. Now, I personally do a lot of these cases, especially if they're like this. I may do them, front back. I may do an A-lift with perk screws. Okay, if that's what you do, talk about it. How do you do an A-lift? Right? Well, I work with an access surgeon and ABCD. And then I flip the patient, I do percutaneous screws. What are your landmarks? Do you use fluoroscopy? Do you use navigation? So you've got to be able to articulate how you fix an L4-5 spondy. The wrong thing to do here, obviously nobody is going to ever say that, but to say, well, I'm going to do a laminectomy because I have foraminal disease. You can't do a laminectomy with an isthmic spondy or a lytic spondy there at L4-5, right? So and then all those cases, you'll get questions on what are the intraoperative adjuncts you're going to use. Are you going to use a microscope? And if so, why? Are you going to use neuromonitoring? And if so, why are you going to use neuromonitoring? What modality are you going to look for? In a high grade spondy, maybe not like this, maybe a little bit higher grade, you may say, well, I'm going to use neuromonitoring because I want to be careful of how much reduction I do. I don't want to aim for a complete reduction because that may cause traction and that may cause a foot drop. So I'm going to do just, minimal reduction. So be thoughtful about the adjuncts you use, and you're going to be asked, well, why do you use them? And just like we had in our case today, we were doing a case, and I was asking one of the trainees, okay, well, what happened if the motors, if we lose motors, what are the steps? You'll be asked that. You'll be asked, okay, you're doing this case, maybe not this one, maybe like a thoracic or one of the previous thoracic or cervical cases. In the middle of the case, you lose motor signals in the lowers. What do you do? And then now you have to have an algorithm for that. We check the leads, we check the blood pressure. We make sure that there wasn't any new anesthetic on board. We may get an X-ray just to confirm that nothing has shifted or subluxed. So if you say you're going to use something, they're going to ask you, well, what happens when it doesn't work, or what happens when it gives you a necessarily a true positive or a false positive, right? But this is a lytic spondy, and you can say front back, you can say all back, you can say MIS, you can say open, but you're going to need to be thoughtful about how you fix spondylolistheses at L4-5 and at L5-S1, whether they're isthmic, dysplastic congenital, or degenerative. Those are very common questions. And never forget here, now obviously here I'm showing a focal x-ray, but especially in degenerative cases, never forget to say, well, I'm going to get standing x-rays, I'm going to look at the parameters, so we're not fusing a patient in kyphosis, or we're not causing flat back deformity, right? So these are more like kind of a high level kind of spine, little pearls for spine. So, and then again, complications here, you can get so many complications. You can get a wound infection, you can get pseudoarthrosis. Hey, patient comes back in 6 months with haloing around the L4-5 screws. Patient has back pain, the cage subsided. Well, what do? Well, now you have to have a revision strategy. I'm going to go in, I'm going to take the screws, I'm going to go to L4, I'm going to go to S1, and then you're going to keep doing that. And then, 3 cases later, somebody's going to say, well, did you check the bone health? Did you get a bone density scan? The patient's got osteoporosis all of a sudden, and you forgot to treat that. So you want to make sure you don't forget the medical optimization, especially when a patient comes back with hardware failure or pseudoarthrosis. Smoking, diabetes, bone optimization, and bone health are big ones here. But those are just, I think, 3 or 4 cases just to highlight the different types of presentations that sometimes we see on these exams. Pretty straightforward in the sense, there's no zebras here. They're showing you common pathologies, whether it's cervical myelopathy, thoracic intradural, especially thoracic intradural lesions. They love those. And of course, lumbar degenerative cases and lumbar deformities. I didn't show it here, but maybe for another session down the road, neurological cases. They love neurological cases, right? Cases with neurological diagnoses that should not be operated on, right? Everybody knows those. Multiple sclerosis. Somebody comes in, you think it's myelopathy, it turns out to be MS, right? MS plaque. You don't want to operate on MS. You think it's a spinal cord tumor, but it's a MS plaque. Big no-no. Somebody comes in with mild cervical spinal cord compression, very mild, and patient is losing motor function quickly, and all of a sudden you're saying I'm going to do an ACDF or an arthroplasty when the patient probably needs neurology evaluation with EMGs, and all of a sudden they have ALS or something, neurologic. Should not be operating on those patients. So as much as these are neurosurgical exams, we still, and we do it every day, we're sometimes we're putting on our neurology hat. And whenever the imaging doesn't match the clinical picture, the history and exam, you have to kind of think about it a little bit. Does the patient need more workup? Do they need more a neurological workup? Do they need EMGs? And this is a side point now, and I see some students and some students here on the call on the chat and fellows. And this is where we go back to the basics. It's so cliche to say, well, you got to do a good history and exam. And yes, neurosurgery is very much driven by imaging. But I promise you, we see this in practice virtually every week, where somebody comes in with lumbar stenosis. Nobody really sat down and talked to the patient for more than 2 minutes to understand that they really have myelopathy. Well, they're stumbling because they've got hyperreflexia and they have severe cervical stenosis. So all of a sudden, you're missing a cervical stenosis because you think it's this lumbar degenerative disease. So a history and exam are really important to, first of all, not be distracted by the image that they're coming to you with, and more importantly, to make sure that you're not operating on somebody that didn't need surgery to begin with because they have a neurological condition like ALS, MS, Parkinson's. Those are big 3. Parkinson's, ALS, and multiple sclerosis are big ones. And the other very, very big one, they show you a lumbar degen case, and it's, a patient's falling, can barely walk, and all of a sudden you're like, oh yeah, it must be that mild degenerative disc disease. It's not. It's higher up. It's either in the thoracic or cervical. So you've got to know the difference between long tract signs and and peripheral neuropathy, lower motor neuron disease, etc. So history and exam are important. imaging, of course, is very important, but don't forget about the basics. So I think we'll stop here. I'm hoping that in the future and I know we'll do this every 6 months or so. One of us, either myself or one of my colleagues, will present more cases like this and walk through them and talk about differential diagnosis, treatment, and potential complications. So on a personal note, for colleagues who are taking the ABNS exam in the next, I think in 2 weeks, if I'm not mistaken, in 2 weeks here in the US, wish everybody the best of luck. Hope everybody. This is a little plug for the Goodman, for the AANS Goodman course, which I usually teach in, but this time I'm not because I'm traveling. But that is a great course run by Dr. Alan Levy every 6 months. It's the AANS Goodman course, and many of us actually have taught in that course and showcases like this. So just a little plug for that course. But thanks everyone for hanging in. It's great to see some familiar faces. Hilberto, how are you? It's good to see you.
Good to see you, Dr. Baaj.
Good to see you. All right, guys, have a great night, and we'll be back next Thursday with another virtual spine session. Have a great evening, everyone.
Bye, everyone.